Hello, everyone. I'm Dr. Ben Sessions. I'm the Laboratory Director of Reproductive Care Center in Sandy, Utah. We're part of the Boston IVF Network, and we're putting this together as part of the National Infertility Awareness Week to bring some awareness to preimplantation genetic testing, which we'll refer to as PGT. And we'll talk some of the basics and just so you understand the process and what it entails, and some pros and cons about it, and hopefully give you a better, I guess, educational foundation on preimplantation genetic testing. An embryo has 46 chromosomes, has 23 pairs, a pair of chromosomes from each gamete provider. So half comes from the sperm, half comes from the egg. And then when the sperm and the egg fuse together, they create the new embryo, which has a full complement of chromosomes, of 46 chromosomes. Preimplantation genetic testing helps us to test the chromosome complement, or the number of chromosomes in those embryos. But there's different types. We have PGT-A, which is preimplantation genetic testing for aneuploidy, PGT-M, which is preimplantation genetic testing monogenic, and then we have PGT-SR, which is preimplantation genetic testing structural rearrangements. And I'll go into each one a little more detail to explain what they all mean and how we interpret those results. PGT-A, or PGT aneuploid, it references whole chromosomal abnormalities, so a full gain or full loss of a chromosome. So aneuploidy is looking at, that's when you have an abnormal number of chromosomes in the embryo. When they have the 46 chromosomes of the normal complement, we refer to those as euploid embryos. And so PGT-A will just strictly look at the total number of chromosomes present in an embryo. The benefit of that is that it can help detect extra chromosomes, a gain, so like a trisomy 21 or Down syndrome, or even a trisomy 18, Edwards syndrome. But it also can pick up a loss of a chromosome as well. The biggest thing to keep in mind is that as a woman gets older, the eggs that she has have a higher chance of being aneuploid or chromosomally abnormal. Typically, once a woman reaches the age of 35, and as she gets older, the chance of aneuploidy or whole chromosome abnormalities greatly increases. And so, it'd be a great benefit for those, as you're doing your family planning later in life, and as you're getting 35 and older, it'd be a great conversation to have with your physician to discuss whether PGT-A testing would be beneficial for you. PGT-M, or monogenic or single gene, is looking for single gene disorders such as cystic fibrosis, Huntington's disease, and whatnot, and also sickle cell anemia, to give a couple examples. So it's a screening tool for helping couples who have been diagnosed as either carriers with these disorders or affected by these disorders. And they don't look at all genes, but just those single genes that the parents are known to carry. And so with the PGT-M, you would need to undergo some additional testing. Typically, you'd have to have some blood drawn. You'd have to be tested to make sure that you are a carrier or your partner is a carrier for that single gene disorder. But the way it looks at so it's strictly looking at single genes. The other one is PGT-SR, or PGT structural rearrangements. And what it looks at is, in essence, where the chromosomes or portions of the chromosomes are rearranged. You can have duplications of chromosomes, you can have deletions or partial deletions of chromosomes, you can have inversions, translocations, where a section of a chromosome is actually moved to another chromosome. Again, with this, you would need to undergo some previous testing to be diagnosed or to indicate that this test is necessary. It's called a karyotype, and that is where they look at the actual physical nature or structure of your chromosomes to make sure that they match what is expected and there aren't no structural rearrangements. With PGT-SR and PGT-M, they are often used in association with PGT-A. And so when you do have a structural rearrangement or a single gene disorder, they can also test for aneuploid for those chromosomes. And so you can have both those results to help pick what we would believe to be the embryos that are most likely to result in a pregnancy, those that are euploid and not affected with a single gene or the structural rearrangement. So one of the benefits of PGT-A, SR, and M and of genetic testing is it helps identify chromosomally normal embryos. So that's with the PGT-A, and also SR and M. And it increases the chance of successful implantation. Now, logically, if an embryo has a full complement and the correct complement of chromosomes, we would expect it to implant at a higher rate than those that are affected with abnormal chromosome numbers. The nice thing with PGT-A is it also reduces the chances of miscarriage. And it also has an approximate 98% accuracy in detecting major chromosomal abnormalities. And the other benefit is obviously you would be able to learn the sex of those embryos if you choose to have that information. And so you can use that information later on for family balancing. It's always good to try to decide on genetic testing in coordination with your physician and your genetic counselor prior to starting your cycle, because there is an increasing amount of insurance coverage for this now. And so we want to make sure that we know your coverage and know which laboratories to send your samples to. So if you know that you are a carrier for a single gene, or you do know that you have structural rearrangements, you would have to provide a blood sample and be tested for those genetic effects prior to your IVF cycle, as would your spouse or partner. And then we'd have get those screening test results back to see what you are a carrier for, and so then we can decide or determine whether PGT-M and SR is needed, and PGT-A would be beneficial for everyone. You'd come through for an egg retrieval. We'd retrieve your eggs, and then we would fertilize your eggs either with conventional insemination or where we would inject a sperm into it with intracytoplasmic sperm injection, or what we abbreviate ICSI. The following day after ICSI and insemination, we'll do the fertilization report. We'll see those that fertilized normally, and we'll culture those embryos out. In my lab, on day 3, we perform assisted hatching. So for us to be able to safely, or for us to actually be able to perform the biopsy procedure, the cells need to be outside of the zona pellucida. The zona pellucida is a protein shell that surrounds the egg that helps prevent polyspermy. And so on day 3 of embryo culture, we go in with a laser and create a hole in the zona pellucida, which allows the cells to herniate or to pop out, and for us to be able to safely perform that biopsy 2, 3, or 4 days later at day 5, 6, or 7 of culture. And when we're performing the biopsy, the layer of cells that herniates out is the trophectoderm layer of the embryo. There's 2 cell types at this stage of development. You have the inner cell mass, which develops into the fetus, and the trophectoderm, which develops into the placenta. Obviously, we don't want a biopsy from the inner cell mass that's contributing directly to the fetus. And so when we're performing that biopsy procedure, we're cutting off those 3 to 5 cells from the trophectoderm layer, which develops into the placenta. And that is the layer with the most abundant cells. And the idea is that we're minimizing the trauma to the embryo. But then also studies have shown that the trophectoderm layer, that the chromosomal status of that layer is indicative or duplicates the chromosomal status of the inner cell mass, which develops into the fetus. And so we continue to culture them. And then at day 5, that's our first check to see if they're able to be biopsied. And then we will biopsy and freeze those that we can. Those that we biopsy on day 5, we will cut off the biopsies. We'll put them in tubes, put them in the freezer. Then we will freeze your embryos and put them in liquid nitrogen. The next day, we'll reassess the embryos. Hopefully there's more to biopsy as well. Repeat the same process. And if they're still developing, still growing, we'll go out to day 7. And it's once we've completed the biopsies on all embryos is when we will ship the biopsy samples to your genetic testing company of choice. And we wait for those genetic testing results to come back. And that's typically 7 to 10 business days for the aneuploid cases. And those for the single genes, those can take longer, 2 to 3 weeks upwards at times. But once we get those results back, we will correlate those results with our embryo freezing records, and we'll match them, and then we will have a member of our team give you a call and discuss the results with you. And so hopefully, there are embryos to transfer, and we would choose those that are obviously chromosomally normal or euploid, or not carriers for the single gene, or the balanced translocation, or whatever the structural rearrangement might be. And then we would schedule and plan for your frozen embryo transfer. On the day of your embryo transfer, we would then thaw that embryo that matched the criteria we needed. And if you had a gender preference, we would select the gender preference of choice. But then at that time, no, obviously, we would witness everything we do. We would have a second set of eyes verify that the right embryo is pulled, that it matches the test requisition that we received from the physician. And then we'd go ahead and proceed in thawing that embryo. We thaw one embryo at a time. And again, no, we have great success rates now. 97–98% of our embryos survive the thaw. And so then once that thaw's done, we'll snap a picture of it and have everything ready for your frozen embryo transfer. And so now previously I talked about the fresh cycle coming through and when we would perform the biopsy procedure. It could also be done on embryos that were previously frozen and already stored in the tank. So just remember that every time we freeze and thaw an embryo, there is an increased risk of the embryo not surviving, which is one drawback to doing it after the fact. But no, it is definitely a viable option for you if you're wanting to see what the gender or sex of those embryos are, and also to confirm that they are chromosomally euploid before transferring them again. But we can thaw the previously frozen embryos, perform the biopsy, and then refreeze them, and then wait for those genetic testing results to come back before we thaw the embryos again for a subsequent frozen embryo transfer cycle. So with the embryos, when we're choosing them for the embryo transfer, obviously we take into consideration the genetic testing results, which reflects the chromosomal numbers of those embryos, make sure that they're euploid and not abnormal. But we use that hand in hand with the morphology grades that we assign the embryos. So we use a modified Gardner system where we assign a number as the expansion grade, and then we assign two letter grades. One references the inner cell mass, and the other references the trophectoderm layer, which is the group of cells, or the layer of cells that we biopsy from. With that, we do the morphology grading. We assign those three letters. It's either A, B, or C. But we kind of use those as an additional data point, if you will, as selecting the best embryo for transfer. We find that embryos of better quality, those that are frozen on day 5, and obviously those that come back as chromosomally normal or euploid, do have a higher rate of implantation, a higher success rate, and so we would preferentially choose those first. Now the nice thing with genetic testing is it is a screening test, and then it gives us an additional data point for us to help pick out those embryos that have the greater chance or the higher viability of resulting in a pregnancy. PGT is a great advancement. It's a great screening test. It does help us to select the chromosomally normal embryos and hopefully get you to pregnancy faster, and then hopefully reduce the amount of miscarriages that you'd have to suffer through as well. And so, it's a great option we have for our patients and helping you build your families.